And I'm going to talk about what to do with toric lenses. And we're putting in more and more toric lenses, not just for our graft patients, but with the extended depth of focus lens, the Symphony. And I'd say over half of ours are toric. And unlike the Acrosoft, this lens doesn't seem to stick to the capsule very well. So I find that at least 10% of the cases, when we look at it the next day to a week later, it's not where we put it. And so it has to be rotated. And the question is, where do you rotate it? And this is even more of a problem for the eyes that we do that have had previous RK and AK incisions, because very often after you put a lens in, the astigmatism changes when you do cataract surgery, no matter what I do to prevent it. So there's going to be two screens that are important when you're looking at your post-operative toric IOLs. And the internal one is basically telling you where it thinks that the lens is. And then the one in the middle, the cornea wavefront map, is basically giving you the cylinder on the anterior surface of the cornea, and matches up with the topography you see on the right. But what I like about it the best is it just tells you rotate at 18 degrees. Now you got to watch that closely, because you don't know which way you can rotate it unless you look at the two pictures and get it figured out. This one, on the other hand, tells you which way to rotate it. So it always tells you how to do it clockwise. So this is 162 degrees, which is the same as going 18 degrees back the other way. And so these are nice to have, and what I've gone to do in surgery because of this is I don't mark them out in the pre-op area like I do for surgery, but I actually just mark them at the time under the operating microscope, two places. First, I mark where the lens is currently rotated or located here, and then I'm going to back it off. This is a different case because it just shows a little bit easier. They're farther apart. In this case, we are rotating it to here. So that's basically a 55-degree rotation. And so sometimes it's clockwise, sometimes it's counterclockwise, because I don't think we know how much these lenses spin once they're in the eye. And some of them spin a while. And of course, the patients like to think you did something wrong, and I have to explain to them that that bag's a little bit bigger than the lens, and it takes a while for it to shrink wrap down. So I usually wait a week or two before I reposition these to make sure it's going to stay snug in the lens, in the capsule. And could you click on that? This should be a video down at the bottom. Yeah, there we go. So this is basically what we do. This is under topical. We usually use a nurse anesthetist when we do the cataract, but I don't do that for these cases. We just usually do topical. Very often I'll put a 4L silk traction suture in the sclera at 12 o'clock if they're moving around at all. We put some 1% xylocaine in the eye. And if it's fairly recent, I won't put any viscoelastic in. If it's been a while, or it's a case that's come from somewhere else, and I have to open up the bag or there's any scarring, then I'll put viscoelastic in and just irrigate it out at the end of the case. And since you have the marks, you check it once you get the viscoelastic out too, to make sure it hasn't moved. But that's basically what we do. I think it's just really great. My entire staff understands how this works, and it's made taking care of these toric lenses really quick and easy. It's a quick procedure in our surgery center.